Please welcome moderators, Doctors Eve Tsai and Sanye Dong.
So thank you very much for attending. I'd like to welcome you to the Spine Trauma Updates in Practices. And we're supposed to have a 2-minute introduction, but I'm going to cut it short and because we're going to have discussion. And I think that's the biggest part that we want for this is to have interaction and discussion. So there's microphones in the back as well. So if you have questions and things like that, we'll have that. So we'll call our speakers up and then we'll have them sit seated. And then at the end, we'll have a discussion with all of them. You want to introduce the first speaker?
Yeah, sure. Good morning, everybody, and thanks everybody for coming. So our first talk is going to be given by Sam Shabani on imaging and MR, tractography, and ultrasound in spinal cord injury. Thanks, Sam, for coming.
Good morning, everyone. Sam Shabani from Medical College of Wisconsin, presenting on behalf of Dr. Shekhar Kripat. Unfortunately, couldn't make it. The development of diffusion and perfusion MRI as a prognosticating and treatment tool in a spinal cord injury patients. These are acknowledgement. A lot of the studies funded by NIH as well as DOD, and multiple individuals were involved in the studies that needs to be acknowledged as well too. So before I start, I'd like to present 2 index cases. One is a 29-year-old who presented Asia A, was taken emergently to the OR. At 6 months follow-up, he actually converted to Asia E. And the second one is a med student who was involved in a diving accident, unfortunately, presented Asia A, was taken again emergently to the OR, but he has stayed Asia A at 1-year follow-up. So the main question is that when we see these 2 patients and look at the pre-op MRIs, how do we determine who will benefit, neurologically will improve, to what extent, and how could we determine that? Currently, we have some problems with our conventional MRI. The conventional MRI has there's a big evidence that it has a prognosticating capability, and actually the only study shows is that Dr. Arabi that looked at the lesion length as well as the hematoma length and the functional or neurological outcome as a 6 months follow-up. And in reality is that when we look at the MRI in patients with a spinal cord injury, it really gets lost in the translation due to the motion artifact from the patients or significant distortion of the cord from the trauma, hematoma, disc herniation, and so forth. So we have many challenges in terms of using MRI for patients with a spinal cord injuries. Technically, a spinal cord is very small. Number 2 is that it's prone to the motion, as well as there is a distortion of the spinal cord that can happen because of the trauma. In terms of the prognostic accuracy, as we can see, the MRI, the T2 has a diagnostic sensitivity, but currently it has a low prognostic accuracy. And when we look at the clinical translation in order that has been done or needs to be done, diffusion MRI was developed and it is sensitive to injury, but it has not been adapted in our clinical practice right now. And still there is an unmet area to look at the cord perfusions or blood flow, as well as dealing with a metal artifact from in the patients with a spinal cord injury postoperatively. So this is there has been many collaboration done in terms of developing and looking at the diffusion tensor imaging, which is very sensitive to the axonal injury at the site of the injury, above the site of injury, and as well as dealing with the artifact postoperatively. And many centers, including us, have been dealing with this in order to advance the MRI. And this is actually one of the first papers that we looked at the diffusion indices at the level of the injury, above the injury. And what we notice is that actually the diffusion indices decreases a couple of segments above the level of injury and can predict the neurological recovery in patients. How about dealing with the post-op instrumented patients and the mirror artifact? And as you can see, this is a patient who underwent posterior decompression fusion in setting of a trauma. And if you look at a conventional MRI without the metal reducing artifact software, there is a significant distortion of the cord in terms of from the artifact, both sagittal and axially. But the new technology has been developed, such as Maverick protocol by the GE, that significantly reduces the artifact. That led us to better look at the cord postoperatively in terms of the sagittal and axial, and be able to do more advanced imaging studies. So advances in the diffusion MRI in the spinal cord. As we talked about it, the DTI was developed, which is, again, sensitive to the axonal injury, but never adopted in the practice, and no one is using it right now. And recently, diffusion-rated imaging was developed, which is applying such as a subtraction, digital subtractions, And by applying filters in the parallel and as well as the perpendicular to the cord, we can reduce the artifact from the edema as well as the CSF, and also enhance the visualization of the injured site in the spinal cord. And when we apply this, actually the main thing that's very important about this is that can be adapted in the practice. It really reduces the acquisition time. It's literally less than 3 minutes. There is no more post-processing or obtaining any region of interest, as well as it really eliminates any variation between the scanners, which has been significant problems in terms of adapting DTI in our clinical settings. And we looked at rat models, and we saw that actually the diffusion-weighted imaging is able to predict chronic outcomes in the rat models with a spinal cord injury. How about looking at the spinal cord perfusion and the blood flow? The arterial spin labeling has been used in the brain, but there's very few studies that looked at the perfusion of the spinal cord and the blood vessels of the spinal cord with the setting of a trauma. And this was applied in the rat model in our centers, and as you can see here, there's a clear loss of perfusion at the site of an injury 24 hours post-injury. And we further advanced this by looking at the time encoding as well as the vessel encoding, arterial spinning. And as you can see is that in the time encode, we can see there is a watershed area. It can relieve the watershed area in the spinal cord, as well as the vessel encoding can actually capture individual arterial anatomy and the cord perfusion in the spinal cord. And then we apply the diffusion and the perfusion in the rat model, but we see that as the lesion expands, the perfusion contracts in the spinal cord. And also in the rat model, the spinal cord blood flow at 4 hours is the best predictor of long-term functional outcomes. So overall, in summary, the conventional MRI has a weak prognostical capability. Diffusion MRI has been developed. The preclinical study shows that it can detect the functional outcome. The early human studies are consistent with the preclinical findings. In terms of the perfusion MRI, the preclinical findings are pretty fascinating, and it can be done. And we are actually in the process of applying it to the human subjects. And hopefully in the near future, we can have some promising results. Thank you, everyone.